In this particular lecture, we're going to talk about acute viral hepatitis. All hepatitis virus are RNA viruses except for hepatitis B, which is a DNA virus. They systemically infect the liver and produces almost always the same manifestation. We'll see patients with jaundice, right upper quadrant pain or tenderness, and body malaise, fever, and other constitutional symptoms. The patient can also come into your clinic with only mild or no symptoms at all, especially when you have hepatitis B infection. Or you may see patients with moderate to severe and even fulminant hepatic failure, specifically for those who are blood-borne viruses like your B, C, and D virus. With regard to hepatitis A, the incubation period is on the average 4 weeks. The replication is limited to the liver, but may also be found in bile, stools, and blood. The viral shedding in feces diminishes. The viremia and the infectivity diminish once jaundice becomes apparent, meaning to say, patient will experience vague right upper quadrant pain, then he or she is shedding the virus during that time, and once jaundice sets in, then the viremia and the infectivity also diminished. The antibody that can be detected in hepatitis A is the anti-HAV. This is present during acute illness, and aminotransferases like your ALT and AST are almost always elevated. The predominant immune globulin is the IgM class that may persist for several months. And upon convalescence, the IgG class becomes more predominant. Once you have an anti-HAV IgG, when your patients come in for annual physical examination or any type of examinations that they do, once you have your IgG class positive, then the patient already had hepatitis A, and it cannot be, or he or she cannot be reinfected anymore. In diagnosing, so we have already mentioned in diagnosing hepatitis A, the anti-HAV of the IgM class should be present. After acute illness, the IgG will predominate, and this is how it looks like. So you have your fecal AHB, we have already mentioned. The ALT will be elevated. The viral is shed in the feces way before jaundice sets in. And when jaundice sets in, the viremia will drop drastically, and your IgM will continue to rise for several weeks and then decline after 4 weeks, where your IgG, anti-HAV of the IgG class, will slowly elevates until this is the convalescent period until it is indefinitely positive when you see patients in your clinics. Whereas your hepatitis B, as we have mentioned, this is the only hepatitis, which is a DNA virus. And usually, the major envelope protein is the HBS antigen. The largest gene, the P codes for DNA polymerase, is the gene P, and the C gene codes for the nucleocapsid proteins, HBE antigen, and HBC antigen, the intracellular core protein. Ibig sabihin, the C gene has two codes, the pre-C region or the E antigen and the intracellular core protein or the C antigen. Here is the representation of it. The P represents the DNA, and the C, the pre-core, and the S antigen. This is very tedious to memorize. It is actually not clinically important. It is just good to know where whenever you have your examination. And here, as I mentioned, although chances are I will not give this to the exam, it is nice to know that hepatitis B is an intact 42 nanometer virion with 27 nanometer nucleocapsid core particle. The antigen on the surface of the nucleocapsid is the B core antigen, corresponding to the anti-core. So medyo magulo yan, pero there are several nomenclature that you will encounter. But more importantly, you have to have a good grasp, as I always remind my students, being a doctor, you have to have a good grasp of what is happening, the pathophysiologic mechanism, how it is transmitted, how it is uh, transmitted, how it is treated, and how it is prevented. So the third antigen is the E antigen. So you have your S antigen, your E antigen, and the core antigen. You have your S antibody, your you have your E antibody, and the C antibody. Among those, the E antigen, this is a qualitative marker of the HBV replication and relative infectivity. It only means that if you cannot afford the viral DNA level of your patient, this is a surrogate marker of the infectivity. You have to remember this. This might come out of the exam. The E antigen is the qualitative marker of HBV replication and relative infectivity. During the course, HBE infectivity disappear, and there may be an improvement in resolution of infection. But persistence of E antigen beyond the first 3 months may be predictive in the development of chronic infection. This is how it goes. You have your S antigen first appear, and then after several weeks, 2 to 3 weeks, then the E antigen will appear, while the S antigen may persist or may decline up to 24 weeks upon exposure. After several weeks, around 4 to 8 weeks, then the anti-E will appear. And correspondingly, after the S antigen appears, then slowly the anti-HB core IgG type will start to elevate. And the goal is for the S antigen to become anti-HBs. But if you have patients who acquire this at birth, chances are the S antigen will progress up until the patient is in adult adulthood rather. Some 1% will develop the anti-HBs. So if you if you see patients with anti-HBs positivity, only anti-HBs, then it did not come from HBs antigen, but rather from vaccination. But if you happen to see anti-HBe, anti-HB core, and anti-HBs, the antibody came from the natural infection. After acute hepatitis B infection, we have mentioned also the first virologic marker to be found is the S antigen. In typical cases, HBs antigen becomes undetectable 1 to 2 months or 4 to 8 weeks, as we have mentioned, after the onset of jaundice. Anti-HBs should disappear and the HBs antigen should disappear after the onset of jaundice, and anti-HBs should appear and be detectable indefinitely. But unfortunately, those who acquired the infection at birth doesn't develop this kind of antibody production, but rather HBs remains indefinitely if the patient acquired this at birth. Those who acquired it in early adulthood would develop anti-HBs after HBs antigen disappeared, if this is acquired into early adulthood. While E antigen is what we have mentioned, a qualitative marker of HBV replication. In chronic HBV, S antigen remains detectable beyond 6 months. The magic number is 6 when you have the word chronic. And anti-HB core is primarily of the IgG class. And anti-HBs can either be undetectable or at low level. In early chronic hepatitis B, the HBV DNA can be detected both in serum and hepatocytes. This is a quantitative detection of the replicative stage. And in this time, maximal infectivity and liver injury is happening. If you will tell that HBV in viral DNA is the quantitative, the HBE is the qualitative marker. So if you have patients with E positivity, E antigen positivity, then the patient is infective or in a replicative phase. When you have your anti-HBE, then it becomes the non-replicative phase or the seroconversion of E positive to anti-E positive. At least 16 major in hepatitis C, there are at least 6 major genotypes, and these are called the quasi-species of hepatitis C. If patient acquires HCV, if the patient acquire HCV infection either by IV drug use or blood transfusion, then HCV RNA is present. So this is the most sensitive indicator that your patient does have HCV infection when you go to order for HCV RNA. Normally, none of the hepatitis are directly cytopathic, meaning the hepatocytes will harbor the virus without causing any inflammation because they are not directly cytopathic. There is what we call the inactive carrier in hepatitis B, wherein because it is not directly cytopathic, the liver histology will remain normal. An important distinction is stressed between HBV infection acquired at birth, wherein this happens in endemic areas such as the Far East, including the Philippines, and if the patient acquired it during adulthood, early adulthood, which is fairly common in the Western part of the world. Meaning to say, at birth, the patient acquired the virus during neonatal period. So there will be immunologic tolerance because the hepatitis B is not directly cytopathic. The SGPT, SGOT, or the ALT or AST will remain normal, and there is an absence of acute hepatitis illness. So therefore, if you acquire it neonatally, then chronicity is almost always the rule. And then HBs antigen will remain almost always also during lifetime. In contrast, when you acquire this in early adulthood or adolescence, the immune response tends to be robust. There is an acute hepatitis-like illness. You will have elevation of your SGPT, SGOT, or your ALT, AST. And with regard to hepatitis C, the pathogenesis, it is cell-mediated immune response and the elaboration of T cells. There is also what we call the extrahepatic manifestation of hepatitis C, which is immune complex mediated tissue damage. Since all the viral hepatitis is not directly cytopathic, the immune complex response, the immune complex that is produced is the pathogenic culprit in the manifestation, especially in the extrahepatic manifestation of acute hepatitis B. You also have the serum sickness-like syndrome, wherein the deposition of HBs and anti-HBs in the tissues or blood vessel wall. And you also have the glomerulonephritis with nephrotic syndrome and the mixed cryoglobulinemia as extrahepatic manifestation. There is a typical morphologic lesions among all the types of viral hepatitis. You have your panlobular infiltration, hepatic cell necrosis, hyperplasia of Kupffer cells, and variable degrees of cholestasis. In severe hepatic histologic lesion, there's a bridging hepatic necrosis. There's also subacute or confluent necrosis or interface hepatitis, and it is observed occasionally in acute hepatitis. These are the features of the hepatitis viruses from A, B, C, D, and E. You have your incubation period, the onset, the transmission, the clinical severity, whether we use prophylaxis or the therapy, and so on and so forth. You may have you 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 may want to have a good grasp on this table because it might come out of the exam. Acute viral hepatitis occurs after an incubation period that varies according to the responsible agent, meaning to say, the prodromal symptoms are systemic and variable depending on the incubation period, wherein you have your range from 15 to 45 days in HAV, in HBV and HDB, up to 180 days or 6 months, in HCV, up to 160 days, while on HEV, up to 2 months. Constitutional symptoms would be anorexia, nausea, vomiting, fatigue, myalgia, headache. This may precede the onset of jaundice by 1 to 2 weeks. There is a low-grade fever, 38 to 39, dark urine, and clay-colored stools. The onset of clinical jaundice, as always, will set in after the prodromal symptoms diminishes. The liver becomes enlarged and tender, splenomegaly and cervical adenopathy in up to 20% of cases. Complete biochemical recovery is to be expected in about 2 months when it with regard to hepatitis A and E, and in hepatitis B and C, the clinical biochemical recovery is from 3 to 4 months. Serum aminotransferases, AST, and ALT show a variable increase. Hepatitis A, we have already had this in other part of the lecture. Diagnosis is based on detection of IgM anti-HAV during acute phase. Whereas in HBV infection, HBE is the marker of infectivity. And serum HBV DNA is more sensitive and quantitative when it comes to hepatitis B detection. So again, try to memorize this table. It might come out of the exam. Assay for HCV. This is the gold standard when it comes to HCV. HCV RNA, the most sensitive. And in acute hepatitis, you see patients with jaundice. You have to have a test for HBs antigen, anti-HAV, anti-HBC IgM, and anti-HCV. So please, those tables that I've shown you, please memorize them. It may come out of the exam. Virtually all previously healthy hepatitis A patients, recovery is the rule. In advanced age and with serious medical conditions, sometimes the presentation is more severe, whatever the hepatitis is. And in contrast, hepatitis C is less severe during the acute phase as compared to hepatitis B. There is also what we call the relapsing hepatitis, which is weeks to months after the apparent recovery from acute hepatitis. This is characterized by the recurrence of symptoms, elevations of aminotransferases, jaundice, and fecal excretion of HAV. There is also what we call cholestatic hepatitis, wherein you have protracted cholestatic jaundice and pruritus. Hepatitis A remains self-limited and doesn't progress to chronic liver disease. The most feared complication of hepatitis is the development of fulminant hepatitis, wherein you have a massive hepatic necrosis. But do not worry, this is a rare event. Those patients with comorbidities are almost always the special group of patients that you have to have a special attention being given. Hepatitis B accounts for more than 50% of fulminant hepatitis, and the remaining chronically, they are the neonates, patients with Down syndrome, patients on hemodialysis, patients with HIV. Chronicity is a late complication of hepatitis. Only hepatitis B and C are among the hepatitis that proceeds to chronicity. Okay, an antiviral with nucleoside analog is given for severe hepatitis B and not for mild to moderate. Whereas in acute hepatitis C, due to progression to chronicity as the rule, then you will have to give interferon therapy. And high-calorie diet is desirable because the patient is in a catabolic state. You have to have a good source of calorie, and it is best tolerated in the morning. And those drugs that are metabolized by the liver should be avoided in patients with hepatitis infection. And glucocorticoid doesn't have a role in acute viral hepatitis. It may play a role in other forms of hepatitis, like alcoholic hepatitis, but not viral hepatitis. And in fulminant hepatitis, you need to have a good fluid balance, circulation, the control of bleeding, correction of hypoglycemia, and the treatment of complication. And in treatment, protein should be restricted and non-absorbable antibiotics should be administered. There is a current prophylaxis for hepatitis A and B, and also indirectly you prevent hepatitis D or the delta in spreading when you have vaccinated your patient. In the absence of active and or passive immunization, prevention of hepatitis C just includes behavioral changes, limiting of exposure to infected person. There is no immunization at the moment with regard to hepatitis C. So with that, thank you for your kind attention.